Hey, thank you. Thank you, Stacy, and I'm happy to be here, and I hope you enjoy this case study. So today we are in case 6 of our case study programming. Today we'll be comparing fibrosis stage 3 and fibrosis stage 4. My name is Robin Soto. I'm a family nurse practitioner. I work in hepatology at UC San Diego Health, and I see patients with all-cause liver disease in the ambulatory setting. You can use this QR code to register for this meeting and give it to any of your friends who may need to register. Madrigal, our sponsor, has disease state education. You can visit the GHAPP MASLD MASH Community Network to view Madrigal MASH disease state education and Madrigal Resmetirom promotional programming. So let's get into our case. This is Sam. He is a white male, and he was referred to you for mildly abnormal transaminase levels, and with his abdominal sonogram, that shows increased liver echogenicity, and he is having some fatigue. And note that his BMI is 33. So Sam's medical history includes diabetes type 2, hypertension, hyperlipidemia, sleep apnea, and he endorses this. He does not drink alcohol. On physical exam, he has an obese abdomen. He does not have any stigmata of advanced liver disease, and you palpate no hepatosplenomegaly. For his medications, he's on lisinopril, rosuvastatin, ezetimibe, and dapagliflozin. So you want to note in his history, looks like he pretty much has all the MASH or MASLD risk factors. So with diabetes type 2, hypertension, hyperlipidemia, and sleep apnea. His vitals look pretty normal. His blood pressure is relatively normal. He's afebrile. Again, his BMI is elevated. He's 235 pounds. In his labs of note, his ALT is elevated at 85. His AST is 72, which is also elevated. His alkaline phosphatase is 120 or normal. His T-bili is normal. His platelets are within the normal range, and his A1C is at 7. He also, for his kidney function, his creatinine is 1.1, INR is normal, his ferritin is a little elevated, and his iron sat is normal. His ANA has low positive at 1 to 80. His anti-smooth muscle antibody test was normal, and he doesn't have active hep C or hep B. So we want to first look at his fibrosis assessments. We have 4 types of non-invasive tests here. And for Sam, we have tested his fibrosis stage with all of them. The first one is a calculation, the FIB-4 score. And in his case, his score, which can be calculated on any medical calc program using the AST, ALT, platelets, and his age, his score came out to be 3.1, which puts him in sort of an intermediate risk area. And so if you see the scale, if his FIB-4 is less than 1.5, we consider him at low risk for fibrosis. If it's over 3.25, we consider him at high risk for fibrosis. And he is pretty much squarely in the middling range where it's sort of indeterminate. It could be that he's leaning towards no fibrosis or maybe advanced fibrosis. So he's really kind of in a gray zone. The next results are from our FibroScan, our VCTE, which is vibratory controlled elastography. And his FibroScan is 11 kilopascals. So again, we're looking at his fibrosis score ranges, and if his fibrosis or his FibroScan result was in the 2 to 7 kilopascal range, we would consider that normal. In the 7 to 9.5 range, that's kind of F1, F2 range, so mild to possibly moderate fibrosis. And again, in his case, we're sort of landing in this mid-range where 9.6 to 12.5 is considered significant fibrosis. So this well could mean F3. And if Sam's FibroScan results were over 12, we'd consider advanced fibrosis. His CAP score measures the level of steatosis in his test. And in his case, again, he's squarely in the middle at moderate steatosis. If his score was above 268, he would then kind of fall into the severe steatosis category. So he's pretty close, but he's not quite there. And then a commercially available blood test called the ELF test puts his result at a severe level, or likely an F3, F4 situation based on the ELF test. So there's some variability between these NITs or non-invasive tests. So the first question for you, if you want to answer, or for me to answer, is, are there any further tests you would order? And how would you stage this patient?
Am I supposed to answer this? I think I'll throw a regular ultrasound as well, just to have a baseline. And I'll just do what you told me, like before FibroScan and the ELF score.
Yeah. And so it sounds like he probably had an ultrasound because they said he was referred for steatosis, but I would certainly want to look at it.
You're right. Yeah.
So if it exists, I would definitely want to see. And I might, so I'm in the specialty space, but I might consider doing a hemochromatosis workup. His ferritin is slightly out of range, and certainly fatty liver can cause ferritin to be elevated. And his SAT is normal, his iron SAT. So maybe if I was worried that this was not something like MASLD and MASH, I might do that. But again, that would be something, if you're not in specialty, that maybe you would refer the patient out to get that workup done. The other thing I thought of maybe is, even though his anti-smooth muscle was normal, he had a low grade elevation of 1 to 80 on his ratio for his ANA. So I might consider autoimmune globulins to just kind of vet that to see if that was really something. But again, I agree. I think, you know, looking at the anatomy and making sure that we're not dealing with something more advanced would be exactly what I would do. And so as far as staging, it's interesting because there's some of the NITs are concordant, but there are some that put them at more severe stage. And honestly, it feels like in clinical practice, that's always how it is. It's never cut and dry. It's never perfectly high or perfectly low. It's always somewhere in the middle. So again, you know, you get to make that clinical judgment in your case. And so then the next slide, I hope I didn't skip a slide, but I don't think I did. How would you treat them and how would you monitor him? So I did not answer the staging question. In my opinion, he's probably an F3 with some possibility that's maybe it's higher, maybe it's lower, but I would feel pretty comfortable calling him an F3. And so then the next question would be, how would you treat him and how would you monitor? So currently, firstly, always with our MASLD and MASH patients, the first line therapy is lifestyle modification. So we want to get deep in the weeds on what he's eating, make sure that he has information on what we would consider a healthy diet. He is overweight or obese, and so there would be some big advantages of him losing weight to help manage his steatosis, and also recommendations for activity, exercise that could help him. But lifestyle modifications in MASH and MASLD are always the primary management. But now we do have one FDA-approved treatment along with lifestyle management for at-risk MASH, which would be how we staged Sam. So that would be a great way to give him the opportunity to potentially move back a stage in his fibrosis. So if he was considered at-risk MASH with potentially an F3 staging, if he gets on Resmetirom and does his lifestyle modifications, he could potentially move himself back into an F2 state, which includes much less inflammation and much less risk, right? The other opportunities we have are to consider the GLP-1s. We certainly know that those are great for weight loss. They're great for diabetes management. We could give him a benefit for his sleep apnea. And we also know that if he were to start one of those, he would get a cardiovascular benefit. At this moment, there's not an FDA indication for prescribing this specifically, this class of drugs specifically for MASLD and MASH. That may be something that happens in the future, but now he would benefit. A lot of his risk factors could be, really mitigated with this consideration. Now, so the tricky question is, do you monitor him for HCC? So the AASLD, or our professional group guidelines, really recommend against monitoring patients with F3 fibrosis with HCC screening. However, I myself, in a large academic setting where I practice, we actually do screen all of our F3 patients with ultrasound and tumor markers every 6 months. So the guideline is a weak recommendation according to the AASLD guidance, but it is something that not every place and not everywhere do we screen. So now we're going to take the same patient, same profile, and then change a little. So let's go look at Sam 2.0. Here he is, still 55, still male, BMI still elevated, has all the risk factors for MASLD and MASH. He's still not drinking. His physical exam is the same, and he's still on an ACE, a couple of cholesterol-lowering medicines, and a GLP-2 for his diabetes. His vitals haven't changed. Again, obese, pretty good blood pressure, afebrile. His labs are a little different, though his ALT and AST levels are still elevated. Alphos is the same. His T-bill is a little bit up compared to our last case scenario, and his platelets are lower. So something may be going on here. His A1C is still not optimized at 7. Creatinine is creeping up also. INR remains normal. The ferritin level of elevations is the same, and all the other tests are the same. So everything's pretty much stable except some of those values in his complete blood count panel and his CMP. And so that can impact the results of the NITs. So in this case, we're looking at Sam's FIB4 at a 3.11. So he's still kind of in that middling area. We don't really have more information about where this is other than he's at intermediate risk. His FibroScan, however, is up to 21 kilopascals. And so he is actually way above the threshold for advanced fibrosis or cirrhosis in his case. So again, pretty clear and telling FibroScan results as long as it met quality criteria and there wasn't any, something that might have interfered in the quality of the test. CAP score actually is less. So again, he's at moderate steatosis, but really much more evidence of advanced fibrosis. And the same with his ELF. So he goes above the threshold for cirrhosis in the ELF. He's above threshold for significant fibrosis cirrhosis in the FibroScan. And the other two are kind of hanging out in the middle. Again, is there any further testing you'd like to perform on this patient? And how would you stage this one? And Valerie, I think here it's super pertinent to look at the imaging, because at this point you want to know, is there evidence of portal hypertension, right? You're going to want to look at his spleen size. You want to look at his, if he has ascites, his bile duct size, and everything to kind of make sure that he may not have even, decompensated cirrhosis or portal hypertension.
Right, those look like cirrhotic. At this time, like MRE or biopsy is overkill, I think. We have a pretty good evidence. Maybe in the future, I'll talk about doing a endoscopy with the patient.
Absolutely. Absolutely. So we are seeing eye to eye on this. And so how would we treat this patient and how would you monitor? We do need to be careful because in patients with cirrhosis, we would not use the Resmetirom. So that would be something that we would not use as treatment here. Certainly lifestyle management is still going to be paramount. And so again, the monitor for HCC, again, the diet and lifestyle. And again, AASLD recognizes that a healthy diet can include a Mediterranean diet. So getting some good oils, good fiber, less saturated fats, less highly processed foods, less high fructose corn syrup. So certainly focusing on things like that that can really make a difference. And especially if he's cirrhotic, we'll want to really talk about protein in his diet, making sure that he's getting a good high protein diet to help with his muscles, and also help mitigate sarcopenia or muscle loss. And also we'll want a low salt diet also. Again, absolutely we'll monitor for HCC. So he is at significantly increased risk for developing hepatocellular carcinoma because he's cirrhotic. So AASLD strongly recommends screening with ultrasound and the tumor markers every 6 months. And again, that's something that is very important to emphasize, that if he just happens to miss one of these screenings, HCCs can grow quickly. And if he has a big lesion and we miss our opportunity to find it early, we can lose opportunities to treat him local regionally and may, have to deal with advanced stage cancer that can be harder to manage and involve much more systemic therapies. Same, I agree with you, Valerie. We probably do want to get an upper GI. We want to see if he has varices. Also, ulcers and things that could put him at a higher risk for GI bleed. It wouldn't be something I would do urgently, but it's certainly something that I would at least consider. And also, based on his FibroScan score, his 21, his bilirubin is elevated, and his platelets are below 500. He meets Bovino criteria, and that would indicate that he has a fairly high risk for clinically significant portal hypertension. So you would at least want a baseline endoscopy in this patient. So I agree with you there. So again, the head-to-heads here. If you're lucky, you get all of your NITs in a line and they all agree. But most of the time, if you're trying to figure these things out and you do one or the other, or you do more than one, you don't always get concordance. So, and certainly to your point, There may be a place for MRE or even biopsy if there's other things that we're worried about in his case. I think we would round out our chronic liver disease workup. We would look for genetic problems. We would look for the more rare liver diseases, just to be clear. But this patient has certainly our highest on the differential for etiology would be fatty liver. So again, in clinical practice, you're probably not going to get a super clean picture, but usually we do like to err on the side of screening more aggressively than we don't. So again, the management, the real difference is HCC surveillance. And as I stated before, in our practice, we actually surveil our F3s because unless we have biopsy, we don't always, believe that we're absolutely able to distinguish between an F3 and an FR. And in our practice, that we have access to the FibroScan, we have access to MRE, we have access to shear wave. So it makes it pretty easy for us to get patients those tests. But as far as like the Fib4, I mean, that's a great test because that's just one of those quick gestalt on what are we dealing with here. They're not perfect, but they're pretty good and they're well validated. So I like that as an opening way to look at a patient's labs. And again, those labs are available in any workup you'd probably do. And then, like I said, with the indeterminate NITs, sometimes you sort of compare and contrast and see, what quality of exam you like most. And again, you're not always going to know, so you're going to have to make a clinical judgment. And then, AASLD guidance as far as HCC surveillance, the amount of liver fibrosis in patients with MASLD has been strongly linked to the development of liver-related outcomes and poor liver-related outcomes and death. Bridging fibrosis and cirrhosis are associated with an exponentially greater risk of liver-related morbidity and mortality, and most of those are HCCs. So the screening becomes critical, and you don't want to miss a small tumor that can be easily managed. And there is evidence abounds that this is really the best way to manage your cirrhotic patients. And again, it's every 6 months. The guidelines indicate ultrasound, but again, sometimes we use multi-phase imaging if we want to see other things or we're not getting a good quality ultrasound, and that's important. If the radiologists say we're seeing this okay, but we're not sure, then you probably want to move to a more multiphasic imaging modality just to be sure.